My name is Dr. Jamie Caroon. I am the medical director at the Center for Medical Cannabis Education in San Diego. I manage a cannabinoid-centric clinical practice here, as well as work on various research and consulting projects. This particular presentation is going to be about CBD, and we're going to talk a little bit about how CBD as an isolate or as a highly purified product may be different than CBD in a full or broad spectrum extract. Virtually all of the preclinical and clinical research conducted to date investigating CBD has used the molecule itself, but the vast majority of consumers are using full spectrum or broad spectrum extracts of the cannabis plant that are rich in CBD, but that also contain other biologically active compounds, including other phytocannabinoids like THC. Can we extrapolate all of the findings from the research that was conducted using the molecule itself and apply it to these full and broad spectrum products? Are the pharmacokinetics and the pharmacodynamics the same? Are the dose response curves the same? Are the safety, tolerability, and efficacy profiles the same? Are we comparing apples to apples, or are we comparing apples to oranges? These are very important questions, and they're only going to be answered through research, and we need a stable, regulated marketplace in order for manufacturers of these products to be willing to invest in this research. I'd like to start out by highlighting some differences between a few things. Here we have the chemical formula and structure of CBD on the left, and the same information for CBDA on the right. CBDA is the acid form, and CBD is the neutral form, or the decarboxylated form. Ironically, the plant doesn't actually biosynthesize CBD, it synthesizes CBDA. In conversations about the regulatory status of CBD, you may hear the phrase naturally occurring levels of CBD. It's important to note that scientifically speaking, naturally occurring levels of CBD are likely to be negligible. CBD is really only present in the plant material as a result of spontaneous decarboxylation. It's interesting to note that CBDA is not an FDA-approved drug, and CBD is. Should these molecules be regulated differently? Should raw products be regulated differently than decarboxylated products? And do they have different effects? There are a few models of nausea and vomiting that indicate that CBDA is more potent than CBD for reducing nausea. In this study, the effective dose of CBDA was 1,000 times lower than the dose of CBD. Like CBD and CBDA, hemp and marijuana are different. They used to be distinguished from one another based on their phenotype, their physical appearance, and their intended use. Now these two types of cannabis are distinguished by their THC content. This is the definition of hemp from the 2018 Farm Bill. It refers to a level of THC not more than 0.3% by dry weight. The cannabis plant doesn't actually biosynthesize THC either, it synthesizes THCA. As with CBD, any THC in the plant is likely to be negligible and present only as a result of spontaneous decarboxylation. According to this definition, a large number of marijuana plants may actually be classified as hemp plants. Notice that it says derivatives and extracts, but it doesn't say anything about finished products. Some say that it's implied. But the word dry weight basis and the fact that this is a farm bill suggests that this definition pertains to plant material and not finished products. Nonetheless, most manufacturers of hemp-derived CBD products will tell you that their finished products contain less than 0.3% THC. I still think this needs further clarification. Non-purified cannabis extracts that are rich in CBD are different than highly purified or isolated CBD products. Non-purified extracts contain a multitude of biologically active ingredients. Highly purified CBD isolate products do not. As a result, they likely have different pharmacokinetics and pharmacodynamics and probably different effects. Consumers are often confused by the term broad spectrum, full spectrum, and whole plant. In some circles, broad spectrum has come to suggest that the product is THC free, but I doubt that that's actually the case. Broad spectrum is not a scientific or regulatory term. Fat-free, sodium-free, or decaffeinated, these are scientific and regulatory terms, and there is no such threshold that has been defined yet by science and in regulation for broad spectrum. It's a marketing term, and if it's important that the product be THC free, there should probably be a scientific and regulatory definition for that. There's already at least one lawsuit that I'm aware of an individual that took a broad spectrum product and failed a drug test. Those of us that work with botanical medicines understand how the constituents in a botanical matrix may modulate the pharmacokinetics and pharmacodynamics of one another to produce a synergistic effect. In cannabis, that synergy has a fancy name. It's called the entourage effect. There is no entourage in a highly purified CBD product. There are physically no members of the entourage. Proponents of the entourage effect claim that a lower dose of a full spectrum extract is equal to a higher dose of a highly purified CBD product with fewer adverse effects. In fact, consumers and patients and their healthcare providers seem to be experiencing positive outcomes using doses of CBD in an extract that are well below the doses of isolated CBD used in clinical trials. When you ask scientists and researchers about this at medical cannabis conferences, they often smirk. They don't think that the doses that are being used in these hemp-derived products are enough to do anything. We need to find out. There is some evidence of the entourage effect, however, though not a lot and not of high quality. As I mentioned earlier, this phenomenon is not exclusive to cannabis. So if you consider the broader world of botanical medicine, there is reason to believe that there may be a signal amid the noise here. In the field of medical cannabis, these are the two most commonly referenced studies when advocates seek to substantiate claims of synergy. The first is a preclinical study conducted in mice with experimentally induced localized inflammation, and the second is a meta-analysis of observational clinical studies treating refractory epilepsy with CBD products. In the second study, the meta-analysis, the patients treated with CBD-rich extracts reported a lower average dose than those using purified or isolated CBD, roughly 6 milligrams per kilogram per day as compared to just over 25 milligrams per kilogram per day. And they experienced fewer adverse effects. I want to take a minute to look at this first study a little more closely. These mice were injected with a chemical irritant in the left hind paw, and the investigators looked at a variety of different anti-nociceptive and anti-inflammatory outcomes. These mice were given both isolated CBD and CBD in a full spectrum extract. The title of the study is Overcoming the Bell-Shaped Dose Response Curve of Cannabidiol, and we'll come back to that in a moment. Here is the chemical composition of the extract. This particular extract is almost 18% CBD. It also contains a small percentage of THC, roughly 1%, as well as 1% of CBC and then some other cannabinoids. Is it possible that this started out as hemp below the 0.3% threshold and then became marijuana just by virtue of the extraction and concentration process, because now it's over 0.3%? Interesting question, because then theoretically you could dilute this down again in a finished product and have that THC threshold be below 0.3%. Is it possible to take something that's hemp, magically convert it to marijuana, and then magically convert it back to hemp? This is figure 4 from the study. On the left, we have the CBD isolate, and on the right, we have the extract. TNF-alpha concentrations are on the vertical axis, and the various dosages of CBD are on the horizontal axis. I have replaced the dose of the extract with the dose of CBD so that we can compare apples to apples. On the left, with isolated CBD, we can see that the lowest concentration of TNF-alpha is associated with the 25 milligram per kilogram dose. and that higher dosages are not associated with lower concentrations. This looks like a bell-shaped curve, or at least an inverted bell-shaped curve, and recall that the name of the study is Overcoming the Bell-Shaped Dose-Response Curve. On the right, with the extract, we see a linear downward trend with higher dosages associated with lower concentrations of TNF-alpha. If we look carefully, we can see that 25 milligrams per kilogram of the isolate is roughly equal to between 4.5 and 9 milligrams per kilogram of the extract. It appears just from this study that the dose-response curve for these two products is different, at least in mice. Now we're going to switch gears and talk about the endocannabinoid system and how CBD may exert its effects in the body. The endocannabinoid system is an extensive endogenous signaling system with multiple elements. The three primary elements include cannabinoid receptors, the endocannabinoids themselves, and the enzymes which both biosynthesize and hydrolyze or degrade them. Cannabinoid receptors are G-protein coupled receptors. Two of them have been identified to date, CB1 and CB2. The CB1 receptor is the most densely populated receptor in the human central nervous system. CB1 receptors are mostly located in the central and peripheral nervous system, on neurons and glial cells, and CB2 receptors are mostly located in the periphery, on organ tissues and immune cells. Endocannabinoids are lipid signaling molecules derived from phospholipid precursors in the cell membrane, principally arachidonic acid. They are fatty acid neurotransmitters which are synthesized and hydrolyzed rapidly. They have very short half-lives. Two endocannabinoids have been isolated and characterized to date. Anandamide, or AEA, or arachidonyl ethanolamine, was the first. The name anandamide was taken from the Sanskrit word ananda, which means bliss. And the second is 2-arachidonyl glycerol, or 2-AG. Notice that these compounds look very different from phytocannabinoids, yet they exert some of the same effects. The discovery of the endocannabinoid system began with the search for the active ingredient in cannabis, or marijuana. CBD was isolated in 1940. It wasn't until 1963 that it was actually characterized structurally. It was administered to lab animals and deemed to be an inactive constituent because it failed to mimic the effects of marijuana extracts. THC was isolated and characterized a year later in 1964. It did mimic the effects of cannabis extracts and was deemed to be the active ingredient. Using the endogenous opioid system as a blueprint, scientists discovered a receptor in 1988 that was activated by THC. They named it CB1. 4 years later, anandamide, or AEA, was discovered. A second cannabinoid receptor, CB2, was identified in 1993. And finally, 2-AG was discovered a couple years later in 1995. You may have heard the endocannabinoid system referred to as a neuroregulatory system. This is the classic description. Here we have a presynaptic neuron, a postsynaptic neuron, and the synapse between them. In contrast to classic neurotransmitters like glutamate, which are peptides synthesized ahead of time and stored in synaptic vesicles and diffused from the presynaptic neuron to the postsynaptic neuron, endocannabinoids are synthesized on demand and they diffuse in the opposite direction. They're synthesized in the postsynaptic neuron, where enzymes will cleave an arachidonic acid from the lipid bilayer here. They diffuse in a retrograde direction, not an anterograde direction, and bind to CB1 receptors on the presynaptic neuron. This causes a decrease in calcium levels, which leads to an endocytosis of these synaptic vesicles. This is called depolarization-induced suppression of excitation. These endocannabinoids are actively shutting off the production and secretion of glutamate in this example and preventing excitotoxicity. This is one of the ways in which cannabinoids, especially endocannabinoids, are neuroprotective agents. This is a model of inflammation in the bowel where leukocytes like mast cells and macrophages have infiltrated the bowel wall. Inflammation ensues, and TNF-alpha and other inflammatory mediators are produced and released by these white blood cells. Anandamide is also produced because of the inflammation. It diffuses and activates CB1 and CB2 receptors on the macrophage itself, and this causes a decrease in TNF-alpha and other inflammatory mediators. This is autocrine regulation. It also diffuses to the nearby mast cell and does the same thing. It reduces the production and secretion of TNF-alpha. This is paracrine regulation. These effects ultimately lead to decreased inflammation and leukocyte infiltration into the bowel wall. And this is like the similar slide where we talked about neuroregulation, endocannabinoids turning off a neurotransmitter. Here they are turning off inflammatory mediators. 2-AG and anandamide are agonists of the CB1 receptor. They bind to the orthosteric site of the receptor. THC is also an agonist. When a ligand binds to the orthosteric site, it activates the receptor. CBD, on the other hand, binds to the allosteric site on the receptor. CBD is often described as a functional antagonist because when it binds to the allosteric site of the receptor, it changes the conformation or the shape of the receptor in such a way that decreases the affinity of agonists at the orthosteric site. This is known as negative allosteric modulation, and CBD is often described as a functional antagonist because of it. But CBD interacts with a variety of other receptors and molecular targets in the body. It's not just a CB1 or CB2 receptor functional antagonist. In fact, CBD has been described as a promiscuous molecule because over 65 known molecular targets have been identified. These include receptors outside the endocannabinoid system, as well as enzymes, voltage-gated ion channels, and transport proteins. For example, CBD is an inhibitor of Pha, fatty acid amide hydrolase. This is the enzyme that degrades anandamide. It is thought that CBD can extend the half-life of anandamide and enhance its signaling by inhibiting this enzyme. CBD is also an agonist of the serotonin 5-HT1A receptor. This receptor is a known anxiolytic target. Perhaps this is how CBD exerts some of its anxiolytic effects. CBD is also an agonist of the TRPV1 cation channel. This ligand-gated ion channel is associated with pain and inflammation. Perhaps this is how CBD exerts its anti-inflammatory and analgesic effects. In wrapping up this section, it's important to note that there are many unanswered questions when it comes to understanding how phytocannabinoids, especially CBD, produce their effects in the body. In this next section, we're going to take a look at some studies. These data are from a cross-sectional study I published in 2018, just over 2,400 individuals who reported using CBD products. Approximately 62% of them reported using CBD to treat a medical condition. When asked what symptoms or medical conditions, the top 5 reported were pain, anxiety, depression, sleep disorders, and headaches. There have been a number of studies like this, and there's quite a bit of agreement in terms of the top 3 or the top 4 reasons that people are using CBD products. We're going to focus on these 3 conditions going forward. Most of the clinical trials using cannabinoids to treat pain combine CBD and THC together. There are some that use CBD by itself, but not very many. I'm not aware of a single RCT, randomized control trial, in humans that has investigated the use of CBD in a full spectrum extract to treat pain. This study was published in 2003. It's a double-blind, randomized, placebo-controlled, single-patient crossover trial that was conducted over 8 weeks among patients with some sort of neurological diagnosis that included pain. Most of these subjects had MS or multiple sclerosis, and the clinical trial was very small. Only 24 subjects started it. This study was funded by GW Pharmaceuticals. The research participants received either THC, CBD, or CBD and THC in a 1-to-1 ratio, or placebo. This study had many outcomes, but we're just going to focus on pain. This is Table 1 from the study. Pain was self-reported and measured on a 100-point visual analog scale, where 0 was the worst possible pain and 100 was the best possible pain. Baseline pain was approximately 30, so that's about moderate to severe pain. Statistically significant findings are presented in bold. In comparison with placebo, CBD and THC significantly reduced pain. CBD and THC together also reduced pain, but not significantly. Overall, pain scores improved by about 25 points for both CBD and THC, and a little bit less for both of them together. This suggests that CBD and THC are equally effective, and perhaps even more effective than the two of them together. It's important to note that the standard deviation here is very wide, and this means that some individuals were experiencing a lot of pain relief, and others were experiencing only a little bit of pain relief. You might be wondering what dose these subjects were taking. This is Table 3 from the study. The subjects determined their own dose. They started with a low dose and then titrated upward on their own based upon tolerability and efficacy. The table includes sprays per day, which I have converted to milligrams per day. The average dose roughly looks the same for CBD, THC, and then the two of them together in a 1-to-1 ratio, around 23 or 24 or 25 milligrams per day. This gives the impression that CBD and THC are equally potent. That's not my experience in clinical practice. The previous table gives us the impression that they are both equally effective in terms of treating pain, and that's also not my clinical experience. But I wanted to just point these things out because there is a lot of contradictory findings in this evidence base. Okay, this is the final study I'm going to discuss in this section. This is one of the phase 3 clinical trials for Sativex, the GW drug that has CBD and THC in a 1-to-1 ratio. This study was included as part of the FDA drug approval process for that drug. This is a randomized, controlled, double-blind study in patients with intractable cancer pain. A 30% decrease was the primary endpoint of this study. Notice that when using THC, just over 20% of subjects experienced a 30% or more decrease in their pain, while just over 40% experienced a decrease in pain when using THC and CBD together. There are 2 points here. First, CBD and THC were more effective than THC alone. That contradicts the previous study that we saw. The second is that there's no CBD arm in this study. At least no data was published, so we don't know actually how CBD would have fared on its own. And as a result, we don't know if the difference here that we see between the THC and CBD is an additive effect or a synergistic effect. I mean, is this a part of the entourage effect? We don't really know. This is a pharmacokinetic study that shows that adding CBD to a capsule containing THC increases the bioavailability of THC. In other words, when subjects took 10 milligrams of THC in a capsule, the maximum average concentration was 3.2. But when 5.4 milligrams of CBD was added to the same 10 milligram capsule, the amount of THC that was absorbed was higher, 4.05. So perhaps the increase in or the decrease in pain was simply due to more THC. It probably wasn't because we think that CBD has analgesic effects, but I want to point out that this is a pharmacokinetic interaction, which is part of the entourage effect, which at least as far as I see it. So this is just an example of how these two cannabinoids may be interacting in a way that's difficult for us to measure. Moving on to anxiety, I'm not aware of a single RCT that has investigated CBD in a full spectrum extract to treat anxiety. However, one was announced at a recent medical cannabis conference in Pasadena. This open-label, double-blind trial is using a full-spectrum marijuana extract that is high in CBD. It's a 4-week trial using sublingual administration of 10 milligrams of CBD 3 times a day. I think this is in patients with generalized anxiety, but I'm not sure. There have been a number of clinical trials using isolated CBD products conducted at the University of Sao Paulo in Brazil. These have been small trials using either healthy subjects or individuals with social anxiety disorder. The experimental models typically include a stressor, like a public speaking challenge, and explore various outcomes from subjectively reported anxiety to biomarkers and other anthropometric measures. Notice the dosages here: 400, 600, 900 milligrams, 150, 300, and 900 milligrams again. The outcomes are mixed, but there seems to be a signal for reducing anxiety, at least in experimentally induced social anxiety. I wanted to point something out in this particular study. Notice that 300 milligrams of CBD led to greater reductions in post-stress anxiety than 100 or 900 milligrams. This looks like an inverted bell-shaped curve. 100 and 900 milligrams were no more effective than placebo. When administering CBD by itself, it seems that a medium dose may be more effective than a high or a low dose. And this response curve looks very similar to what we saw in that preclinical study with acute pain and inflammation. What is the dose response curve for a broad or full spectrum extract in anxiety? We don't know. I haven't seen that study. And finally, sleep. I'm not aware of a single RCT in humans that has used a broad or full spectrum CBD extract to treat sleep disorders. You may be recognizing a pattern here. There are only a few RCTs investigating the use of cannabinoids, even fewer investigating CBD. Most of the studies combine them. A 2017 review indicates that CBD may be helpful at higher doses, around 160 milligrams a day. It describes one RCT where total sleep time increased and frequency of arousals were decreased. It also describes 2 other studies using lower dosages of CBD, where CBD was reported to have the opposite of the intended effect. It was stimulating. You may have heard that phytocannabinoids have biphasic effects. This could be an example of that. This is the only RCT that I'm aware of that has investigated the use of a hemp-derived CBD product. It was funded by CV Sciences, the manufacturers of Plus CBD oil. It was conducted over 6 weeks. It included 65 healthy subjects. There were a myriad of outcomes, but I'm just going to focus on the sleep outcomes here: sleep quality and sleep quantity. The investigators reported that both of them improved by over 20%. And I'm not sure how those outcomes were measured because the paper has not yet been published, just the abstract. With that, I will end this presentation with a plea to anyone out there to please invest in research. Obviously, we need a stable, regulated marketplace in order for the research investment to make sense, but there are so many unanswered questions, and people are using these products on a regular basis. We need to have more information so that we can facilitate safe and effective clinical usage. Thank you so much for your time and your attention.